This case study is being brought to you by Jalil Bryant, Otis Green, Monica Webb, and Mary Perrin. Introduction to hypertension. Hypertension is a common condition in which the long-term force of blood against the artery walls can lead to serious health problems. People could be hypertensive while appearing asymptomatic. Hypertension in most cases takes years to develop, and nearly hypertension affects everybody. Introduction to stroke. A stroke occurs when the blood supply to the brain is either interrupted or reduced, which causes the brain cells to die. As people age, their chances of having a stroke increases. And according to Mayo Clinic, if a person's blood pressure reading is 120 reads higher than 120/80, then their chances of having a stroke increases as well. Patient X is a 47-year-old African-American male who has a family history of hypertension. He drinks more than 2 beers daily. He's a non-smoker but eats fast food constantly. He was recently diagnosed with sleep apnea and hyperlipidemia. He has recently been divorced and is fighting for the custody of his 2 kids, and he has a very inactive lifestyle. One night, Patient X and his friends went to Dave & Buster's to watch a football game. Patient X excuses himself to go to the restroom. When he returned to his seat, upon walking to his seat, he started to experience blurred vision and shortness of breath. He sat down and a woman nearby called 911, and the paramedics appeared at the scene and transported Patient X to the emergency.
Hi, I'm Monica Webb. Stage 1, Patient X arrives to the emergency department. Because of his symptoms and history, healthcare workers are concerned about the possibility of a stroke. At this point, a stroke alert is announced. When this happens, a dedicated team responds to assess the patient and carry out a series of stroke alert protocols. Now, if Patient X has suffered a stroke, the protocol includes assessing the patient, obtaining vital signs, and documenting the onset of symptoms. They need to check the patient's blood sugar, administer oxygen, secure an IV, and execute physician orders, including stat labs, which usually include a CBC, a Kim7, and a PT-INR to check the patient's clotting factors. Nurses help coordinate for a stroke patient to have a stat CAT scan. Now, this will be a non-contrast CT to determine if the stroke is hemorrhagic in nature. It is crucial for that CT to be read immediately by a radiologist. If it is not hemorrhagic and the patient was in the 3-hour window, administration of TPA can be performed. A rapid response stroke alert helps to quickly diagnose whether or not the patient suffered a stroke, and if so, which type. Is it hemorrhagic or ischemic? This quick diagnosis helps in treating the patient in a timely manner. Which brings us to our first critical thinking question. What is the evidence-based practice for utilizing a stroke protocol? A study published in Surgical Neurology International states, the speed at which the diagnosis is made and at which appropriate testing is performed is also important because of the need to administer TPA as quickly as possible after an acute stroke, as shorter treatment times have been associated with the improved outcomes. The key here is the onset of symptoms. Nurses, physicians need to find out when the patient was last seen as normal or before those symptoms took place. Question 2. What is the time frame to administer TPA? Currently, that window for TPA administration is getting a little bit bigger. It depends on the facility and the physicians involved. But as of now, according to the Stroke Association, if administered within 3 hours and up to 4.5 hours in certain eligible patients, TPA may improve the chances of recovering from a stroke.
The second part of the scenario starts with the interpretation of the assessment data from the initial tests. The blood pressure of the patient is very elevated, as well as the heart rate. The sugar is elevated. The patient has decreased potassium. The kidney function is a little elevated as well, showing that there could possibly be some damage. And his ABGs show that he is in compensated metabolic acidosis. The CT scan showed no evidence of blockage, but a small area of resolving ischemia in the frontal lobe. So from this point, the doctor will order labetalol in order to reduce the blood pressure of the patient to a safe level. Begin Lovenox, Plavix, and a statin drug such as pravastatin in order to reduce further risk of stroke. Do an ultrasound of the carotid arteries, and then order PRN medication for blood pressure and give orders to notify the physician if the vital signs change drastically again. So the nurse will administer labetalol as ordered, as well as the other ordered medications. Call the doctor with the CT results and continue to monitor the patient's vital signs. So the critical thinking question, first one for this section, is what is the pathophysiology of a transient ischemic attack or mini stroke? It has the same etiology. A clot or a plaque buildup blocks the blood supply to the brain. Only in a TIA, the symptoms will resolve in a few minutes or hours without long-lasting effects. It may, however, be a precursor to an actual stroke, so we have to continue to monitor the patient and give medications to prevent any further damage. The second critical thinking question would be, how would you evaluate the effectiveness of the treatment? And the effectiveness will show as an improvement in the lab results, stabilization of the patient's vital signs, especially blood pressure, and no further stroke symptoms appearing.
All right, my name is Otis Green, and I'm going to be presenting stage 3 of our scenario on hypertension and stroke. The continuation of the scenario, patient X did not suffer a stroke and was diagnosed with primary hypertension. After 3 days on the med-surg unit and stabilization of the symptoms and signs, he was discharged from the hospital. Discharge instructions included Norvasc 5 milligrams every day, losartan 50 milligrams every day, and a baby aspirin. He also was discharged with to modify his diet and to reduce his alcohol consumption. The assessment at discharge, his blood pressure was 134/91, heart rate was 84, O2 sats was 98% on room air. Blood glucose was 128. He weighed in at 112 kilograms. Speech was clear. He had a normal gait, and he was alert and oriented ×3. He had normal range of motion and 5 out of 5 strength in all extremities. Nursing interventions before discharge. You want to ensure that the patient understands the discharge regime. You want to discuss lifestyle changes that could lower blood pressure. You also want to inform the patient to keep a daily log of blood pressure measurements. You also want to discuss signs and symptoms of stroke with the patient. You also want to make sure that the patient is stable and safe for discharge. Stage 3 critical thinking questions. What are the modifiable risk factors for Mr. X as they relate to his lifestyle and hypertension prevention? Also, the second question that you can ask is, when should Mr. X seek medical care if he starts seeing certain stroke warning signs? As far as the answer for number 1, we could talk about reducing alcohol consumption. He should also try to lower his fat intake and is also partake in a low sodium diet. He would also want to lose weight, become more active, exercise regularly, and reduce stress. I know he's going through a divorce, and that probably won't subside until after the divorce is final, but I mean, he should try to find ways of lowering his stress level. As far as number 2, warning signs of stroke. If he starts having trouble speaking, confusion, fainting, and dizziness, weakness, tingling, or numbness in the arms, legs, or face, vision problems, severe headaches, and if his hypertension comes back and is uncontrolled by medication, that's when he should go out and seek medical care.